Persistent patellar tendinitis or persistent patellar tendon pain, despite physiotherapy treatment, is a very common problem and a source of big frustration for many athletes and patients. Physiotherapy, or maybe I should say exercise therapy, is indeed the cornerstone of the treatment for patellar tendinopathy. But unfortunately, it does not always seem to help, or at least not help enough. And the reason is almost always that one of the 7 key principles listed here was not executed or addressed properly. In this video, I will explain each of these, and also I will show you how you can remediate the problem and get back on track. And as you will understand from this video, some of the issues may seem not so important at first sight, but when you look at them from a biomechanical loading perspective, they have actually a dramatic impact towards recovery and successful return to sports and competition. So the key principle number 1 is stick to the basics of successful tendon rehab, which is 1. To temporarily reduce or stop all harmful loading of the tendon. That is, all fast rate tendon loading, such as jumping, hopping, braking, or abrupt stopping, landing, because an overload of these are detrimental to the tendon, and they are in 99% of the cases the cause of the problem. So number 1, reduce or stop these. 2, start exercise therapy and apply the fundamentals on how this exercise therapy should be performed in order to progressively strengthen the tendon so that it becomes capable again of handling fast-rate tendon loading tasks without pain or discomfort. What are these fundamentals of exercise therapy? Well, they have been very well described in numerous scientific publications, such as by Bellemans, Cook, Rio, and many others. The key, and the by far most important thing, is to start with prolonged or sustained isometrics, which means isometric contractions for a long duration, 40 to 50 seconds, and against high resistance. I will explain in a moment. When subsequently the pain is getting better, slowly progress to incorporating heavy slow resistance training. So bring in movement to the tendon, again with relatively heavy load but very slow speed. That is why we call them heavy slow. Heavy loads, slow execution. When this goes better and better, faster loading to the tendon can commence, like running. And finally, you can gradually bring in ultra-fast loading, like jumping, landing, hopping, braking. Now, why is this schedule so important? And why do you have to start with prolonged isometrics? For 2 reasons. Because prolonged isometrics have an important analgesic and decongesting effect on the tendon, which means that they significantly reduce the pain and also significantly reduce the internal swelling of the tendon, which has a further beneficial effect on the pain. And 2, because they are a very, very safe way of strengthening, without risk of causing further damage to the tendon. Now, why that is, I need to explain you with this graph. This graph shows how loading of a tendon can be either beneficial or destructive. On the vertical, the y-axis, you see the load on the tendon. Let's say how much weight you push, either in magnitude or in total volume per day or per week or whatever, it doesn't matter for this graph. On the horizontal, the x-axis, you see the speed of which the load is applied, the load application rate, from static to slow to fast and ultra-fast. So on the left, you have isometric contractions with 0 speed, so no movement, static. Then 3 to 4 seconds loading, like in heavy slow resistance exercises. Then fast loading, like in running. And then ultra-fast, like in jumping, hopping, braking, accelerating, etc. Milliseconds. Now what you see is that slow loading is very safe for the tendon, whereas fast loading is not. And ultra-fast loading is even worse. That is where the danger is. If you do too much or too heavy ultra-fast tendon loading, like jumping, hopping, accelerating, braking, etc., you will quickly cause damage to the tendon. And that is why, on the contrary, static isometric loading and subsequently heavy slow exercises are so safe, and why they are the cornerstone of tendon rehab. They make the tendon stronger, they make the tendon recover in a very safe way, at least if you do them properly. So, how do you do that practically? Well, that is relatively simple. For the isometrics, 40 seconds hold, 20 seconds rest, 6 times. So 40 seconds hold, 20 seconds rest, 40 seconds hold, 20 seconds rest, 6 times in total. The load, as high as you can, 6 times. 1 to 3 times a day. 5 or 6 days a week, 6 weeks minimum. If you are a pro and really motivated, You can even go up to 4 or 5 times a day. And what is important, in fact very important, is that you perform them in close chain and in relatively low flexion angle position, somewhere between 15 and 30 degrees of flexion. Like this, if you have access to a leg press machine, which is ideal. If you don't have access to a leg press, then single leg high squat position is the alternative. 6 times, 40 seconds, up to 3 times a day. Why in a low flexion angle position, between 15 and 30 degrees? And why in close chain? Well, that brings me to key principles number 2 and 3 on my list. Why in a low flexion angle? Because then there is the least compression on the tendon. The deeper the knee goes in flexion, the more there is compression on the tendon by the patellar nose, which is this part of the kneecap. And this compression leads to irritation of the tendon, which we call tendinitis, and frequently also leads to focal damage of the tendon, which we call tendinosis. As you can see here on this MRI of an athlete with patellar tendinitis, and also focal damage to the tendon. So indeed, patellar tendinitis and patellar tendinosis is almost always the result of combined overload and compression by the patellar nose. So that is why you should always stay in a low flexion angle, because then the compression on the tendon is minimal. So you will ask, why not train then in full extension, where the least compression is? Because in full extension, the knee is in its locked position, where quadriceps and tendon activation becomes less active, so it is little efficient to train there. So therefore, the ideal angle for prolonged isometrics is somewhere between 15 and 30 degrees of flexion. You can see this on this graph, which shows the amount of compression relative to the degree of flexion of the knee. This is the ideal zone to train, 15 to 30 degrees of flexion. So as you understand now, stay away from deep flexion angles, because they cause compression and may in fact worsen the tendinitis and increase the damage. Here is another case to show that. Severe compression overload with structural damage to the tendon. The result of training too heavily and in too deep flexion angles. And sometimes this compression overload damage can lead to a real hole or defect in the tendon, as you see here in this athlete during his surgery when we repair the structural damage. I will explain you later in this video how we exactly do that. Number 3. Why exercise in close chain? Because close chain exercises are much safer than open chain exercises, at least in the low flexion angles where we want to exercise in, as I have just explained. What is the difference between open chain and close chain exercises? Well, that is defined by the foot and the lower leg. Any exercise that involves a kicking-like motion is open chain. Like for example, the leg extension machine. That is open chain. Close chain is any exercise where the foot is supporting on a surface and exerts a pushing motion onto that surface. For example, the ground, a platform, a foot plate, a pedal, or whatever. So no kicking, but a pushing movement. Like for example, when squatting, when doing a leg press, the rowing machine, the cross trainer, a training bike. These are all close chain activities. The foot pushes, no kicking. As I said, close chains are much safer in low flexion angles than open chains, because they are much less likely to create overload to the extensor mechanism, which includes the patellar tendon and the patellar cartilage. The reason is that the moment arm for close chain exercises is much smaller than for open chain exercises, which means that close chain exercises are much more friendly for the extensor mechanism, that is the patella, the patellar tendon and the quadriceps. So they have much less risk to creating damage when compared to open chain exercises. In open chain exercises, the moment arm is much longer and therefore much more aggressive to the patellar tendon. In fact, if you want to experience that and develop patellar tendinitis, you should do lots of open chain leg extensions with heavy weights, and you will soon start to feel your patellar tendon and your kneecap hurting. Key principle number 4. When progressing the rehab, monitor closely for the potential appearance of cumulative pain. What do I mean with that? Well, when the pain is getting better with the prolonged isometrics, you start gradually with heavy slow resistance training, so incorporating movement and dynamic reloading of the tendon. We usually do that with a combination of dynamic, close chain exercises such as the squat, the leg press and the hack squat. Typically, this would be a session of 3 to 4 sets of 10 to 15 repetitions per exercise. High resistance, close to the 10 to 15 RM, repetitions maximum, and slow execution. 3 seconds up, 4 seconds down. And this 3 days a week. So for example, Monday, Wednesday, Friday. And on the other days, continue with the isometrics. As the rehab progresses, decrease the number of repetitions to 6 to 8, but increase the resistance loads to an even higher load, around the 6 to 8 repetitions maximum. But still, slow execution, 3 seconds up, 4 seconds down. And stay in relatively low flexion angles, between 0 degrees and 45 degrees, in order to avoid unnecessary compression. You remember the compression graph? So you understand now what you are doing to the tendon and why it is important not to go in too deep flexion. Now, while you are progressing, how do you know whether you are not going too fast? The answer is twofold. 1. The athlete should not experience pain greater than 2 or maximum 3 out of 10. Now, that is somewhat subjective, of course, and therefore there is a second rule. That is, that the pain should never be cumulative. That means progressively increasing over sessions. So, this is okay. There is some slight increasing pain or discomfort during or after the session, never more than 2 or 3 out of 10. And it is back to baseline before the start of the next session. That is okay. That is non-cumulative pain. It does not increase over the training sessions. This is not okay. The pain gets progressively worse. It is the signal that the progress is going too fast. If you continue like that, you will eventually create structural damage to the tendon. In other words, you are making the tendon worse again. You will relapse. And the only way to avoid that is to take a step back, reduce the load, reduce the volume, reduce the compression, and if needed, go back to the isometrics. You've been a little bit too fast, take a step back because there is cumulative pain. And this is especially important in this phase, where you start to incorporate fast loading or ultra-fast loading rates, like running, jumping, landing, braking, etc. That is really a dangerous phase, because then the coach becomes involved, and everybody thinks, oh, it's getting better, we can start to run and hop again, and start lightly training again. And there is a substantial risk of double or even multiple loading schedules, by the physio, by the athlete, by the trainers. And everybody thinks, oh, but I haven't been loading much, whereas in fact, the total accumulation is way too much. So this means that there should be really excellent coordination, because otherwise the trap of overdoing is almost unavoidable. And this is unfortunately so frequently the case. Almost all cases that fail to cure are somewhat related to this aspect. Going too enthusiastic, without monitoring cumulative overload, without counting the total jumps, the total running distance, the number of hops, basically having no idea on the number and volume of fast and ultra-fast loading times. And therefore basically working in the dark, without no one really knowing or realizing. So, key principle number 5, avoid incorporating fast and ultra-fast loading rates to the tendon too soon and too much. Number 6, while you are doing all of this, correct all contributing factors to the development of patellar tendinitis, such as hamstring and quadriceps tightness, hip abductor weakness and core instability, patellar endotorsion, which is frequently associated with VMO insufficiency, intrinsic foot muscles weakness, lateral patellar compression and Hoffa impingement, calf muscle weakness, especially the soleus, which is important for shock absorption during landing, and limited ankle dorsiflexion. All these factors contribute to the patellar tendinitis and must be addressed in the most optimal way. Final point, look also beyond physiotherapy. In our experience, physiotherapy is successful in about 85% of cases with patellar tendinopathy. But in 15%, additional measures are necessary to bring the athlete back to sports at the desired level. Here you see the list of additional modalities that have evidence that they work, and which you may consider depending on the situation. Focused shockwave therapy, not radial doesn't work, PRP injection, and surgery. Focused shockwave therapy is especially helpful when there is significant hypervascularization or new blood vessel formation on power Doppler, which is easy to see on ultrasound. Because these blood vessels are associated with substance P releasing nerve endings, which are important contributors to the pain, and which respond very well to shockwave treatment. A big advantage is also that shockwave treatment can be performed in season, because it does not require an interruption of the program. A strategy that is aimed more at the medium to long term is PRP injection, platelet-rich plasma, which is retrieved from a blood sample of the athlete. When injected into the damaged zone, the platelets then release growth factors that facilitate the healing process. Usually, PRP treatment is done under ultrasound guidance and in 2 sessions, with an interval of 2 to 3 weeks. Surgery is the last option. It can be performed by arthroscopy, that is keyhole surgery, or by conventional operation for the severe cases. During the operation, the damaged tendon area is then excised to healthy tissue in a triangular shape. The patellar nose is removed so that the compression is relieved and the defect is repaired through a tissue shift and sutured in T fashion with resorbable stitches. So, with this, you now know the key principles of treating patellar tendinopathy. Stick to them and you will be successful. Thank you for watching.